Nasopharyngeal carcinoma by Nur Izzah Syahira binti Razali, Sasfinis Fari Kalimutu, and Hashima binti Ibrahim under the supervision of Dr. Hardeep Singh. Epidemiology. Nasopharyngeal carcinoma is a multifactorial disease. Its incidence depends on several factors such as genetic susceptibility, environmental, personal habits, and diet. Etiology and risk factors. The exact etiology of nasopharyngeal carcinoma is unknown. However, there are several factors responsible for this disease, such as Epstein-Barr virus, family history of nasopharyngeal carcinoma, race, which is more common among Chinese, gender, more common among male, high intake of salt-cured food, and heavy intake of alcohol and tobacco.
Next, we move on to pathology. For histopathology, squamous cell carcinoma is the most common malignant tumor of nasopharynx, in which it constitutes 85%, followed by lymphoma, which it constitutes 10%, and the rest 5% are rhabdomyosarcoma, malignant mixed salivary tumor, and malignant chordoma. Grossly, the tumor presents in three forms. Firstly, proliferative form. When a polypoid tumor fills the nasopharynx, it causes obstructive nasal symptom. Secondly, ulcerative form. Epistaxis is the common symptom. And the last one, infiltrative form. Growths infiltrate submucosally. So, what is the roots or spread of nasopharyngeal cancer? The cancer can spread through eustachian tube that can cause otitis media, through nose and orbit that can cause nasal obstruction, epistaxis, and also proptosis as well, through foramen lacerum and ovale that can cause ophthalmic symptom and facial pain, through parapharyngeal space that can cause cranial nerve pulses and also trigeminal muscle trismus, through retropharyngeal nodes that can cause neck pain and stiffness, cervical nodes metastasis that can cause upper jugular and posterior triangle nodes enlargement, and also distant metastasis that involve bone, lung, liver, and other sites.
Clinical features. Neck mass. Most common presentation, painless, unilateral or bilateral. Mass in upper posterior neck, beneath superior portion of sternocleidomastoid muscle close to the mastoid process. Nasal symptoms such as blood-stained post-nasal discharge, epistaxis, progressive nasal obstruction. Otologic symptoms such as tinnitus, otalgia, hearing disturbance, dizziness, and ear fullness. Neurologic symptoms include headache due to skull base erosion, diplopia, and facial pain. Other symptoms include weight loss, anorexia, trismus, and distant metastasis to lungs, bone, and liver.
Next, the diagnosis of nasopharyngeal carcinoma. First, endoscopic evaluation. Endoscopic evaluation can be done under local anesthesia using rigid or flexible endoscope. The evaluation of the growth can be described as proliferative, ulcerative, or infiltrative submucosal. During the endoscopic evaluation procedure, biopsy also can be done. Second, biopsy. Biopsy can be done under local or general anesthesia using endoscope. In some cases, which the growth is not visible but is highly suspected because of metastatic node, blind biopsy from multiple sites in nasopharynx can be done. The third one is imaging studies. Imaging studies such as CT scan and MRI scan can reveal primary growth, erosion of the cancer into the skull base and clivus, extension of the growth to parapharyngeal, retropharyngeal, and intracranial region. Some other imaging studies such as chest X-ray and CT abdomen also can be done to reveal for any secondary lung and liver. In some patients, PET scan is done to see for any metastasis at the other part of the body. And the last one is audiogram. A baseline audiogram is important in patients with nasopharyngeal carcinoma to see for any side effect of radiation and chemotherapy which can cause sensory neural hearing loss. Finally, the treatment of nasopharyngeal carcinoma. Radiotherapy is the treatment of choice for nasopharyngeal carcinoma patients. However, some of them may require chemotherapy in addition to the radiotherapy. Chemotherapy can improve the local control of tumor and to treat the distant metastasis. Basically, for the patient with nasopharyngeal carcinoma stage 1 and stage 2, they are usually treated by radiotherapy alone, while for those patients with nasopharyngeal carcinoma stage 3 and stage 4, they may require both treatment of radiotherapy and chemotherapy. Radical neck dissection is done if there are positive nodes in the neck with no distant metastasis. This procedure includes the removal of sternocleidomastoid muscle, cranial nerve 11, and internal jugular vein.